Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Great. Thank you for inviting me back to talk about hepatitis B clinical management. I wanted to take this opportunity to talk about two topics that I get the most questions about from clinicians, probably because there's not clear guidance in this area. This is my financial disclosure and our disclaimer, and just a reminder that I will be sharing some data, and these data do not give the full picture or tell the whole story of disparities between groups. And let's go into our case. So this is a 54-year-old man who presents after reestablishing HIV care after some loss to follow-up, was diagnosed with HIV and chronic hepatitis B, was E antigen positive, has been E antigen positive, I should say, but was diagnosed in 2010, previously on emtricitabine, tenofovir, DF, and efavirenz combo therapy, but had a history of treatment interruption, history of type 2 diabetes, cryptococcal meningitis in 2012, nadir CD4 of 80, with subsequent renal injury after receiving amphotericin B, and now has chronic kidney disease with a baseline creatinine of 1.8. Resumed emtricitabine, tenofovir AF, and bictegravir in March 2022. And you can see what his viral levels for both HIV and Hep B have been over the ensuing year. So you could see that his HIV viral levels suppressed to undetectable within a few months, but his Hep B viral level has had a slower response. So my question for you folks is, which of the following would you do next? A, send an HBV DNA genotypic resistance testing. B, review adherence. C, add entecavir 1 milligram once daily, or add entecavir 0.5 milligram once daily. Oh, interesting. Yeah, so the majority of you guys wanted to check genotypic resistance testing and to review adherence, which I would agree with both. I think I would probably review adherence first before I would send the genotypic resistance testing, but yeah. This question of persistent HBV viremia, despite this discordance with HIV viral suppression, yet persistent HBV viremia, is one of the most common questions I get asked. And I wanted to go over some of the concepts underpinning that. The question that always comes up is, should I augment therapy? Should I add entecavir in this situation? Just a reminder, this is just a summary table of the available hepatitis B antiviral agents. And you can see, they're here alphabetically, you can see that they will vary in terms of their potency and in terms of their barrier to resistance. And at the moment, largely because of these different characteristics of potency and barrier to resistance, our first line therapy is really going to be some version of tenofovir, either tenofovir disoproxyfumarate or tenofovir alafenamide, or entecavir. So those are the first line agents for Hep B. So they're not an exhaustive list, just a reminder. Let's talk a bit about HBV genotypic resistance testing. It's the same methodology as used for HIV resistance testing. It's consensus-based sequencing, and it may not be successful in giving you a result when the viral level is less than 500. Not the case here. We could probably get a result. The data you get with the test is you get the resistance-associated mutations. So you can see what drugs are compromised or not. You will get the genotype of the Hep B virus, which may or may not be helpful. And you would also get whether there is the present pre-core or core promoter mutations, which in a lot of our E antigen positive patients, we don't usually see that. It's usually in the E antigen negative patients that we might see these mutations. The indications for testing are really when you're seeing a suboptimal response in a patient who's on antiviral medication. And what counts as a suboptimal response is sometimes up for debate. And then you will want to get it when there's virologic and with or without biochemical breakthrough. And that essentially means that they manage to get their HBV DNA down appropriately, but you're starting to see a bump in their HBV DNA levels. Usually you want to see more than a couple of logs bump. and you may end up seeing an ALT elevation or biochemical breakthrough as well. We don't tend, in contrast to HIV genotypic resistance testing, we don't tend to get this at baseline. Even if the patient is treatment experienced, it's not necessarily recommended. The other kind of fact to remind you guys of, this case is a good opportunity to remind you all that the kinetics of HBV viral decay is much slower with antiviral therapy than it is for HIV or Hep C. And it relies greatly on immune-mediated viral clearance. So the immune system needs to be involved for a brisker drop in viral decay, and you need a Hep B host response. And that may be why patients who are e antigen positive, who tend to be a little more immune tolerant of the virus, as this patient is at particular risk of slow clearance. So we conducted a study in the CENIX cohort, which is a network of 8 clinical Center for AIDS research sites across the US to examine factors associated with delayed HBV viral suppression on tenofovir-based ART. And we found that looking at this group as a whole of people living with HIV who had chronic Hep B, most of them were e antigen positive. 48% of 397 patients, only 48% actually achieved HBV viral suppression to less than 200 from the start of their ART in our observation period. And the median time to HBV suppression was 28 months. That's a long time. That's way longer than we tend to see for HIV. So that's just a reminder that, and the range was wide. Some of the factors that was associated with this delayed suppression was, whether they were exposed to lamivudine before. And by lamivudine, I include emtricitabine in there. And when I'm saying that specifically, I'm saying, a lot of our patients have had their HIV for a time, and they had it for a time before tenofovir was even available. So they essentially had what we would think of as functional lamivudine or emtricitabine monotherapy for their Hep B. So that was like the only active HBV active drug in their armamentarium. So that experience really influenced how quickly they suppressed. So it was 17 months to achieve viral suppression. That was the median timeframe for those who were lamivudine naive, and 50 months for those who are lamivudine exposed. Other factors included high baseline viral level, much like our patient, and low nadir CD4. These were independently associated with like a lower likelihood of like prompt HBV DNA suppression. And our patient here has all of these risk factors for delayed HBV suppression. The other important factor that our study didn't measure was medication adherence. HBV is much more sensitive to lapses in adherence than I would say HIV is. And this is based largely on my clinical experience, but we see this discordance with HIV suppression and persistent HBV viremia again and again. And I think it often is reflected in patients who are missing some doses. So this was a study of 4 hospitals in Melbourne, Australia, where investigators found that the medication possession ratio of less than 80%. So this is based on pharmacy dispensation records, where you can tell if patients were kind of delayed in filling their medication, that they were probably missing some doses. And this was associated with a greater incidence of what they termed unfavorable virologic outcomes, which they essentially defined as lack of viral suppression. So we always have to review adherence with these folks. So I'm not quite sure that I would pull the trigger with entecavir for all the reasons kind of stated here. So one of the things to be aware of is this lamivudine resistance. Hep B lamivudine resistance is quite prevalent in our co-infected population. And you can see here that entecavir, like tenofovir, when the patient is lamivudine naive, is actually, pretty robust regimen. But if the patient has lamivudine experience and may have some Hep B lamivudine mutations, the entecavir shares the same resistance pathway as lamivudine. So once you've acquired the YMDD mutation for Hep B lamivudine resistance, it's much easier for you to develop entecavir resistance. So entecavir may not be quite as durable as we'd like it to be. The other thing I warn people about is how it has a long half-life. And just like we have seen people develop NNRTI resistance with just interruption of efavirenz because of its long half-life, we can see the same thing happen with entecavir. We have to renally dose adjust. And I always tell people it is not more potent than tenofovir. It relies on the Hep B immune response just as much as tenofovir AF or TDF does. So it's not as much of a rescue agent as you would like to think it would be. So those are just some caveats to be aware of when you're thinking about augmenting with entecavir, that you might not get as much bang for your buck with some of our patients. So I want to spend some time talking about this question, which is the other one I get asked a lot. So with this patient, should they undergo HCC screening? Great. So it seems split somewhat with yes, of course, and it depends. And it sounds like no one was like clear about saying no HCC screening. Yeah, I think I would agree with both A and C. And let's go over some details. So liver cancer, hepatocellular carcinoma is one of the leading causes of cancer-related deaths worldwide. And chronic Hep B is really a leading cause of this. It is common among people with HIV, but we don't actually have a clear sense of what the determinants of, we haven't had a clear sense of what the determinants of Hep B associated to HCC are. It hasn't really been that well characterized. And we attempted to do that because most of our current knowledge really comes from Asian cohorts with Hep B without HIV. So in this study that I want to go over, we sought to identify the factors that was associated with HCC, specifically in this co-infected population. And this was the paper. So I'm sharing work that was presented in CROI 2021 and published in Hepatology later that year. And we conducted essentially a longitudinal cohort study within the North American AIDS cohort collaboration. And this is for those of you who don't know about any cohort, it's a collaboration of clinical and interval HIV cohorts from Canada and the United States, and 22 cohorts contributed to this analysis. Our study included patients 18 years and older who had at least 6 months of observation within the cohort, and the years spanned from 1995 to 2016, who had evidence of chronic Hep B as defined by a positive, surface antigen, e antigen, or DNA level, and had HIV viral level or CD4 measured during that time. So we attempted to exclude prevalent HCC. So we didn't want folks who already came to us with liver cancer or who had evidence of severe liver injury with an ALT, AST that might suggest they had more of their acute Hep B. So we were trying to really look at the chronic folks. Our primary outcome was HCC, which was adjudicated either through linkage with cancer registry data or by medical chart review using a standardized abstraction protocol. So our cohort, their baseline characteristics are shown here. The median age was 43. Most were men, 41% Black. 6.3 met our criteria for diabetes at baseline, and heavy alcohol use and chronic co-infection were common, with just over 35% and 21% respectively. The majority had HBV DNA assessed, and of these, a minority, about 27%, had only qualitative results. This was mostly the VA folks. Of those with quantitative HBV DNA, the baseline distribution is shown here, with nearly 38% with viral levels exceeding 2,000. E antigen was assessed, not in everybody, but just under half of the participants being E antigen positive. And at baseline, 76% were on HBV active ART. Of those, 28% were already on tenofovir DF. Many of these patients eventually ended up on HBV active ART during the course of follow-up. 19% had low platelets, which serves here as a surrogate for advanced liver disease. So that was our group that we looked at. So among 8,354 individuals, 115 actually developed HCC for an incidence rate that's shown here, 1.8 per 1,000 person years, for a median follow-up of 6.9 years. In our first Cox proportional hazards model, we looked at HIV and traditional liver-related factors, and among these, age, heavy alcohol use, and chronic Hep C emerged as independent risk factors for liver cancer. Notably, HIV viremia and CD4 percentage weren't found to be associated with HCC risk. In the second model, among those who had quantitative HBV DNA, we looked at the risk of HCC by viral level, adjusting for age and calendar year follow-up. And we looked at this 3 different ways, using variant cutoff categories as a time-updated variable. And it was very clear that detectable HBV DNA greater than 200 was associated with a 2.7-fold increased risk of liver cancer, and the risk was especially elevated at viral levels exceeding 200,000. Finally, in a third model, and we included those who had qualitative or quantitative viral levels, we looked at the risk of HCC by their duration of HBV viral suppression. So kind of looking at the corollary. And we examined this as sustained suppression, meaning consecutive months of undetectable HBV DNA. And we found that this sustained suppression for at least a year was associated with a 58% reduction in HCC risk. So there was a dose-response relationship with how long you were suppressed and this protective effect. So our study was really the first to show that even a very low viral level, using 200 as a cutoff, was associated with HCC risk in a fairly large racially diverse cohort of adults outside of Asia. And I highlight this because it stands a little in contrast to the Taiwanese data, the REVEAL HBV cohort, which is the data that everybody cites. They reported a higher risk of HCC with a threshold of 2,000. I think these data basically highlight the importance of ongoing HBV DNA surveillance and optimization of HBV DNA suppression and the protective effect that sustained and ideally uninterrupted suppression of HBV can have in reducing HCC risk. But when it actually comes down to HCC screening in people with HIV and chronic Hep B, few studies have actually examined this specifically in this cohort. We don't have direct evidence for effectiveness of HCC screening in this population. We have used ultrasound surveillance as kind of our standard practice for HCC screening, but it's an imperfect screening modality. It is not as sensitive as we like it to be, particularly in patients who have more elevated BMIs or who have fatty liver, where they've got a very echogenic or bright liver background. It's sometimes hard to discern a new nodule or new mass in that setting. And the other thing I kind of point out is that HIV-associated immune suppression clearly has an adverse impact on carcinogenesis and tumorigenesis, and that's the case with liver cancer as well. So we really need to look at this HCC prevention more rigorously in this population. In the absence of these data, I actually tell patients, I'd like to do liver cancer screening with you, but I just want to let you know that, a lot of the data that we have to support this is extrapolated. And so we don't actually know for sure if ultrasound screening benefits, but, it's based on extrapolated data, but here it is. So I agree. I think I would screen this patient. I would send him for FibroScan because, honestly, knowing whether someone has cirrhosis is really important. And it remains one of the strongest predictors of liver cancer. Given his older age, his diabetes, and his antiviral history, which had some, periods of lapses, I would definitely consider this guy moderately high risk and would consider him for HCC screening, perhaps even if he's not cirrhotic. If he had chronic Hep C, I would definitely prioritize treating that. And if you were drinking, I would spend a lot of time talking about reduction and cessation and maybe even think about naltrexone. And then in terms of how to screen, the recommendations are really ultrasound, abdominal ultrasound every 6 months. And the American Association for the Study of Liver Diseases makes it optional whether to send a serum alpha fetoprotein. And I can talk about that a little bit more later about why they don't come down firmly on saying we should use a serum AFP. But for the sake of time, I'm going to end here and take any questions.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.